Well, first of all, welcome everybody to the Opportunities in Healthcare panel. We have 5 panelists today, so I don't think we're going to have any shortcoming of information or discussion, especially after talking with some of the panelists. I think they have a lot of ideas to share and a lot of insights. In a second, I'm going to let each one of them introduce themselves, and then we have a couple questions that we'll start off, and then we'll see where it goes. As Marty said, if you have any questions for the panelists, go ahead and put it in chat. I'll be trying to monitor chat while the panelists are speaking, and then I can queue up questions for them as it makes sense. So my name, once again, is Doug Pace. I'm CEO of a company called Stonehill. We're a strategy and innovation firm, and talking about COVID, one of the largest engagements that we just finished is we helped the state of Florida roll out the COVID vaccine across the entire state through the emergency order. So we were on that from January through June. So we know a lot about, and then we also manage a few value-based healthcare organizations, ACOs, as well as some independent physician practices. So why don't we go ahead and get to the introductions. I'll just call on each panelist, and if you could, guys, just spend 2 to 3 minutes introducing yourself and a little bit of your background. Paul, would you like to start?
Absolutely. Yep, great to be here with everyone this morning. Thank you, Doug. Thank you, Marty, for the invitation. We appreciate it. So Paul Barrett, managing partner at a lower middle market healthcare services focused PE firm called Argosy Healthcare Partners, Argosy Capital, headquartered in Wayne, PA, 1.7 billion AUM, started and backed by a family office since 1990. And institutional grade back office and 5 unique divisions, all focused on the lower middle market, generalist PE fund, real estate, credit, and secondaries. And our healthcare group, which we're incredibly excited. We launched January 1st of this year. And again, majority control deals, healthcare services, founder-owned businesses, and really targeting younger founders. Thesis-driven approach. We have about 10 areas of healthcare services that we're focused on. And quickly on myself, spent the last 14 years in New York City, all in healthcare related ventures. For the last 8 years, I was a partner at a lower middle market focused healthcare PE firm, 2 funds, 500 million AUM, phenomenal experience. Had the chance to build our BD and origination program, led 4 portfolio companies, life sciences tools business, a lab services company, tech-enabled healthcare staffing, and dermatology physician practice business. So grateful for that experience, but had to get the kids home. My wife and I are originally from Philly, so just in time for our latest 76ers second round exit, put them in Embiid and Simmons jerseys, and grateful to be home and partnering with a terrific group at Argosy. So we are a standalone management company division firm, and our strategic plan is to do 2 platform investments this year, leveraging the family office capital as well as co-investors if we earn that opportunity, and then hire 2 teammates. And we have our first business that's closing at the end of August, our first teammate that's starting, and then we'll look to do 1 more platform investment to build a base underneath us, and then launch institutional fundraise next year, Fund 1, with the family office anchoring, and obviously hoping to earn the opportunity to bring on other institutional investors that are interested in lower middle market healthcare services, majority control deal, and that's the background on us. So again, thank you for the opportunity to participate in this.
Perfect. Thanks, Paul. Steve, you want to go next?
Sure. You're going to ask the Pittsburgher to follow up the Philly guy. Why not?
Pennsylvania panel.
Yeah, maybe I'll spend a little time talking about the black and gold, just to keep Paul's sports, self-loathing going. But no, thank you very much, everybody, for having me. I appreciate it. And on behalf of both myself and Karma Health Partners. So I'm about a 23, 24-year healthcare guy, came out of college, was lucky enough to jump right into the electronic medical record world. And I've watched the development of the technology platforms change over the last 20-something years, have participated in pretty much every bolt-on product that has been added to the physician or hospital delivery process. So whether that might be, like the Freesias of the world doing the checking in automated forms, all that type of stuff. So I've seen all those different changes. And after about 9 years in corporate sales for Allscripts and Mysis and a few of the big boys, I ended up starting my own consulting firm about 12, 13 years ago, and have focused for the last decade plus on the smaller independent practice, keeping doctors independent, giving them a pathway to not be absorbed by the health systems. Right now, I'm currently involved with Carma Partners. Myself and a few partners founded that right as COVID was hitting last year. It was perfect timing. We were coming out right in February, March timeframe, and ended up putting on hold as everything happened in March. So I think we launched last early May. We have been dealing with several, small and large opportunities where we're helping a 400 doctor organization get absorbed by one of the big MSOs, Village MD, Oak Street Health, Aledade. Those are the types of partners that we've been talking with. We're very focused on that type of model and the opportunity for physicians to remain quote unquote independent in working in a shared risk model underneath a big national umbrella. We're also helping build independent MSOs. We have 2 different MSOs nationally that we're helping to build with the physicians. And at Carma, we are not only consulting the providers, we also have a practice consulting into the vendors. So we have designed a ecosystem that allows us to kind of plug and play very much a value added, kind of enriching type of solution service set into a practice as we talk with them. Everything we're focused on is efficiencies. So robotic process automation, AI, ML. We're focused on anything that can save really hard savings, not the fake ROIs we've seen for years with EMRs, and you're going to get rid of things that you never got rid of. But we're looking at tremendous efficiency savings and moving doctors into a more technology-rich situation and environment. We're also looking at the new revenue generation opportunities that they typically ignore, one of those being in-office retail. Dermatologists are great at it, dentists are great at it, but most doctors are not really even thinking, let alone bad at it. They're just not even thinking about how to monetize their patients every single month. They get their 2 visits a year, and that's typically what they stop at. So we're helping on chronic care management, remote patient monitoring, all those types of tool sets that add revenue. And then we are launching a new company that just came out of the Carma process. We're launching a Amazon-esque healthcare focused platform marketplace that will reduce costs. We validated all of that model over the last couple of years, and now we're actually launching a full business around it. We were able to focus on biologics, which are the human tissue products going into patients of surgeries. And we were able to take the average price of a product down by about 20 to 40%. So an average of about 30. Over the couple of years, and the hospitals that we were working with have now asked us to go more full, broad, service offering. And then we have one other company that came out of our Carma process over the last year and a half, where we are helping to launch a kind of next generation healthcare focused LinkedIn. So a couple of very big, audacious goals that we have set ahead of us with these 3 different organizations, and look forward to giving any feedback or assistance I can on the panel toward what we see from the Carma point of view in healthcare today.
Perfect. Thank you very much. I own some property outside of Pittsburgh, so we'll get caught up later. Joel, how about you go next?
Sure. Thank you. And thank you for having me. So my name is Joel Cantor. I guess following on Paul's opening stuff that Steve followed on, I was born and raised in Chicago, so I got my dream come true in 2016 when the Cubs won. I have lived for the last 43 years in Washington, D.C., where with the Capitals in 2018 and the Nationals and Mystics in 2019, we consider ourselves the District of Champions. Not too much of a slight at the Black and Gold. I spent a little bit of time on the Capitol Hill before moving into the private sector, where I ran a SBIC that did venture capital financing, originally somewhat eclectically from 1990 on. It was all in healthcare. And prior to 1990, it was at least substantially in healthcare. The company went public in 93. It got sold in 1999 in a transaction that made us the 24th largest gainer on NASDAQ that year, which was not a half bad year to be the 24th largest gainer on NASDAQ. So my lesson in all of that was Mark Cuban at Broadcom was number 2 that year. So my lesson was at number 2, you get a basketball team. At number 24, you do not get a basketball team. Ted Leonsis still gets the basketball team, but you get pretty good tickets and kids get cars and life's not so bad. We have continued to do as a family office what we basically were doing in that context since somewhat smaller scale, but we continue to do venture financing in the healthcare space in sort of all of the fields. I'd say over the 40 years, we have financed over 400 companies. I can't think of a kind of service other than ambulatory surgery centers that we haven't done, whether that's for pets or people. Lots and lots of devices, including a orthopedic implant company that used to be in Hunt Valley until it was acquired. And a fair bit of life sciences, in fairness, more in the 80s and 90s, back when it didn't cost $100 million to get through the FDA, but we still do have a couple of therapeutic companies that we're involved with. And a few things that I would call consumer healthcare, in the sense that while we had the clinical trials to demonstrate that this was better for you than anything that was on the market at the time, from an FDA perspective, regulation was not required. And so that was, a good way to help sell practitioners on recommending these products, but it wasn't how you really sell them, because they got sold directly to the consumer. Whereas your part in the real healthcare system is a doctor says something to you like, I'm going to use this sort of implant, and you don't tend to argue any more than you do about which kind of drug they prescribe for you. Examples of that is we were the founding investors in Sonicare toothbrushes, Plax mouthwash, and the Clarisonic facial brush, in case any of those are sitting on your bathroom counters. And that's kind of what we do.
That's phenomenal, Joel. And I actually have to gravitate to your first comments about being the district of champions, because I sit in Tampa, and we hold the lightning in the box, so we Tampa Bay.
I gotta say, you may have taken the crown for sure.
Tom Brady helped.
It's been a rough spring.
Anthony, do you want to go next?
Yeah, sure. Thanks, Doug. Thanks, Marty. I'm in the DC area, so Washington football team. I'm a diehard, fan. Not many of us out there left, right? It's been a tough few years. I'm the CEO of INF Care, and what we've developed is a solution to the home care agency and aging at home problem. We've developed the digital caregiver assistant, which gathers critical data on older adult clients at home, that's driving better decisions and allowing home care to be proactive. We also focus on automating tasks so caregivers can use their time more wisely and more effectively. And then, of course, we provide a virtual care connectivity platform to kind of wrap it all together so that home care can really be structured in a better format for older adults' needs, allowing them to get the care when they need it at a price they can afford. So that's a key thing for me. It's a passion of mine. I started this company because of what happened with my grandmother. Since 2015, I've just been completely immersed in this market, speaking all over the country, and really putting our solution in the hands of older adults and caregivers to really master what we refer as kind of the largest problem here, which is getting older adults to use the technology naturally. And we've developed algorithms that drive natural utilization. And so we focus on low technology literacy older adults, low income older adults, and the other 25 million older adults that are turned away by home care today due to the high cost, the lack of data, and the high operational expenses. We completed some great work with Medicaid. We did a year-long case study, drove some phenomenal results there. We did some work here in Arlington with low-income senior housing and drove some phenomenal results around mental wellness, again, with low-income older adults. So we got a lot of great traction. We're currently raising around to deliver on a contract we have in place, and just staying really busy. We got a lot of opportunities opening up for us, given our expertise, and a lot of the market shifts to focusing at the care at home space right now. So it's a space that we've really mastered, and we're really excited that, given the changes in the environment, health plans, independent living facilities, and even providers all want to keep people at home, and that's where we rest at.
Perfect. We're going to have a lot of questions on that, I know, in the next few minutes. Last but not least, Merritt, do you want to pull us up on the introductions?
Thanks, Doug. Yes, I'm Merritt Widen. I'm speaking to you from the Silicon Valley in California, where the dawn is just breaking. I've been an entrepreneur for 35 years. Since 2009, I have been operating telehealth companies, behavioral telehealth companies. In 2009, I founded a company called Forefront Telecare, and Forefront is now a leader in providing behavioral care via telehealth to vulnerable seniors and operating in 40 states. Last year, I stepped down as chairman of Forefront to start Clarity Telehealth. I'm chairman and CEO of Clarity. And Clarity is a collaboration of some pioneers in telehealth like myself, other healthcare leaders and luminaries. We have the former COO of the Cleveland Clinic, for example, psychiatrist executives that have built and managed large clinical operations in the both the private and public sectors, and world-renowned surgeons. And we've come together to address a problem that is really unmet, and that is the mental health support of people undergoing major surgical procedures. And we're talking neurosurgery, open heart surgery, amputation, mastectomy, bariatric surgeries, certain spinal surgeries for chronic pain, reconstructive surgeries, organ transplants. All of these surgeries are very intimately and closely associated with mental health comorbidities. And untreated mental health problems cause, impede healing. They keep people from adhering to their care and rehab plans, and really increase mortality and decrease surgical outcomes. So we're all about increasing surgical outcomes and helping the surgical community get better results by taking that area of problem off their shoulders. So our long-term vision here is to really bridge the gap between surgery and mental health, which is completely siloed today. And we're looking at a time when, if you're going to have open heart surgery, being referred to mental health support will be as natural as being referred to physical therapy if you're getting a rotator cuff. I think 10 years and maybe 5 years from now, people are going to look back and say, how could you ask somebody to go undergo a major oncological intervention without some kind of mental health support? It's barbaric. So that's our vision. I'm very happy to tell you whatever you want about it. We are the first to this market. There's a big first mover advantage, and I look forward to your questions.
Perfect. Thanks, Merritt. Why don't we start high level and just jump right in? Joel, I'm going to ask you first, because we had a short discussion prior to the panel about some of just the themes that either COVID accelerated or persisted through COVID. So could you just talk about a couple of those themes that you were talking about and kind of lay some framework for today so we can start a discussion?
Sure. So I guess my view would be COVID put a almost unbearable strain on the acute care side of the healthcare equation. I mean, hospitals were obviously overrun. It demonstrated that we, under circumstances like this, have a severe shortage of ICU beds. 94% of all rural counties in America don't have a ventilator in them. Nursing homes, which get paid more for convalescent care than they really do for taking care of people, fundamentally found that they didn't have the money to be able to, unless they were reaching into their own pocket, to be able to keep places clean enough to stop COVID from running through the facilities. And and all of that then creates a huge load on the healthcare workers. I think on the flip side, what it really did is we all were staying at home. So you probably did not do any of the more discretionary things that you might have done once a year or more over the course of 2020 and probably into 2021. So you had a lot of practitioners who were basically trying to figure out how to survive. I've had several conversations with my dentist about how tough that year was and his struggle to not lay people off, but on the other hand, can't really keep the office open. Nobody's coming in. So I think there were a lot of pressures on the system. At the same time, I think on the positive side, miracles always seem to kind of be the overnight sensation. And that's kind of how I think we tend to view what happened with the vaccine. Having said that, sometimes these things really date back years, if not decades. In this case, I think it really is decades. The first research on mRNA started 30 years ago. Oops, am I really gone? No, I'm
You're good.
okay. I got a message that I was signed out. Sorry. First research on mRNA really started 30 years ago. They spent a long time trying to figure out exactly where it was going to be used and how it was going to be used. And even then, as it relates to the pandemic, we benefited a ton from what's happened with the ability to do genomic research on a much broader set of things much faster than was true 15 or 20 years ago. Something like Moore's Law, except that the speed in which we've been able to test genomic stuff has gone even more rapidly than Moore had ever predicted. I do think that things like telehealth, this was a huge wake-up call. I had a little bout with cancer back in 2016 and was treated at Georgetown and just decided to move all of my stuff to Georgetown. MedStar jumped all over, which owns Georgetown Hospital, jumped all over the, we can't have you come in because the hospital is too dangerous to have you walk into. And so, anything that you're trying to come here for, first question we're going to ask is, can we have the doctor do it with you over telehealth? I'm not sure that they've figured out yet how the reimbursement for all of that actually works. And that does strike me as the place where a lot of this is going to rubber meets the road, in the sense that, people do need to be paid. And unless the insurers or the government, if they are the insurer, as is obviously true with Medicaid and Medicare, are the ones who decide, yes, we can pay for this, that, or the other, you're reaching into a smaller population that's going to be trying to reach into their own pocket to pay those fees. But I do think we've learned new ways of providing healthcare that will continue to ride on. And the scars, I personally believe that we've lived in a little isolated world where this has never happened before, but the rest of the world, this has happened every 5 years since 2000. And I just feel like we will live with a bunch of scars from this that will continue to drive behavior. I mean, if everybody really thinks that the emphasis on sterilization and disinfection is just going to disappear because the disease disappears, presuming the disease disappears, I tend to think we're always going to be kind of thinking in the back of our minds, but we were all walking around pretty fat and happy in March of 2022 until all of a sudden we weren't. So.
Perfect. Paula, do you want to continue on the same question? Just keep us at a high level, and what themes are you all looking at?
Yeah, absolutely. And such an extraordinary period of time, and had dramatic effects on healthcare services sectors in different ways. It was tremendous opportunity for some areas, and then kind of catastrophic situation for many others. On the kind of winners end, temporary healthcare staffing businesses, the travel nurse industry, which is the biggest division of that $15 billion industry, grew 2x in the last calendar year. So extraordinary opportunity to fulfill the travel nursing clinician demand, and home health services businesses, everything past the acute care hospital on the post-acute care chain. Anthony knows this. I won't steal his thunder, but related to the home health sector. But that's been a trend that's been happening for many years. It's both patient preference to be served, taken care of in the home, and then obviously the cost component, and that's always the nexus of opportunity in healthcare: superior patient outcomes, patient preference, and lower costs. So, home health services businesses, the trend was already in their favor, but this was certainly an accelerant as people were scared to be in nursing homes and rehab facilities and the dangers presented by that. And then on the pharma services and life sciences tools side, once in a generation innovation and outcome with the vaccines, but also challenging for other, if you're selling in the institutional or academic healthcare setting, those were shut down. So if you're selling reagents or tools or services there, and clinical trials were shut down for a period of time, but they've come roaring back. So it's really it's different pockets. Another tough area was emergency room services. You would think with everything related to COVID that could be an opportunity, but all their elective procedures, which provide the margin, were shut down. So they were so that was difficult. And then the winners out of the COVID situation from a retail healthcare setting were urgent care centers. That we're issuing COVID-related tests and seeing more patients and that type of thing. But retail healthcare, dermatology, dental offices, as Joel mentioned in his conversations, that was really difficult, particularly depending on which region you're in. So really ton of opportunity, but really difficult times depending on where you were in the market.
Perfect. We'll just kind of go, you kind of gave Anthony a layup. So Anthony, you want to talk about home health and kind of the changes that have happened?
Yeah. Thanks, Paul. Absolutely. What we've been watching happening in the home healthcare market is really interesting. It was a very fragmented market going into 2020. What we've been seeing happen since the pandemic is a lot of consolidation, not only amongst home care agencies, but also you're seeing health plans actually reach down and really kind of build a continuum of care from the very beginning of home care all the way through hospice, and of course, including care at a hospital facility. So those acquisitions have been really interesting to watch. We've also been watching a lot of independent living facilities reach out and start to collaborate with home care agencies and really start to address clients' needs before they get into the independent living facility as a way to kind of catch them and reel them in. So that's been interesting. And there's been a lot of joint, ventures we've seen, particularly in Florida, which happens to be a location that's very important to watch when you're looking for trends in this particular segment of this market. So, those joint ventures, again, have been around home care, care at home, servicing clients at home. And so, when the pandemic hit, we saw a lot of people trying to get older adult clients on Zoom. Younger adult clients, this wasn't, much of a problem. There are a lot of apps out there for them to connect. But for the older adult population, it was very problematic. And, the problem still exists where they're trying to connect older adults. They can't, they don't know how to use the technology. They're waiting for the next generation of older adults 10 years from now to reach retirement age, because that'll be a lot easier generation to work with technology. But in the meantime, what do you do for the next 10 years with these older adults? And that's exactly where we sit. And we, again, we focus on those older adults that are really getting left behind in care right now, because they don't have the technology literacy and oftentimes the connectivity. They don't have Wi-Fi. And so you have to have a range of options for them to be able to connect, including cellular. So it's been a very interesting, year where everything is now focused. Home care has really become a very exciting space. We were in it, way before, and no one really cared, about home care because there were a lot of other things going on. But now with COVID, a lot of people have seen what a little bit of isolation does to younger generations. And this is something older generations have been living with for a long time. That isolation, that depression, that, mental, keeping your mental wellness up is a key factor. And then just really being proactive. Right now, the home care market is set up to be reactive. And with our solution, we're hoping to turn the tide and make it proactive by driving it, the right type of data.
Perfect. Merritt, Anthony, you guys must have gotten together before me, because talking about mental wellness and telemedicine or telehealth, do you want to talk about that? And then also, can you address Joel's comment about payment for it as well?
Sure. So, and I shared this with the panelists before we started, but, I've been in telehealth since 2009, and everybody who got into it at that point said, "Oh, this is such a good idea that if you build it, they will come." And they came much more slowly than we ever thought. There was patient reluctance, there was provider reluctance, there was payer resistance, and there was policymaker resistance, very often abetted by the local medical communities, the local medical boards. So, well, we don't want these guys coming in from New York and into Alabama and seeing our population. So there were difficult times, and I not a Mormon, but I felt like the Mormons, trekking through the desert and trekking through the mountains and trekking, and everybody's shooting at you, and it's hot and it's cold and nothing's happening right until you get over the last mountain, and there's the Great Salt Lake. You've made it. And that's how COVID was. COVID was the great coming out for telehealth. And I think one statistic to keep in mind, and telehealth, had phenomenal, growth during the COVID pandemic. And it was completely unsustainable, that kind of growth rate. But, you have to keep this in mind. During the pandemic, 1 in 4 Medicare recipients had a telehealth visit. 1 in 4. Millions and millions of people. Huge. But that means there's 3 out of 4 that haven't yet. And almost all of them will. So there's still a lot of room for growth. And to address Joel's point, the reason that there was a constant friction, I think, between between payers and telehealth, was that there was no strong constituency for telehealth. Maybe in rural areas where they had no alternative, and that was it, right? And now there are people that if their insurance aren't going to cover. There's moms in Boston that are saying, if my insurance isn't going to cover telehealth visits for my kids, I'm changing, right? So they're going to cover it. At the same time, the states are mandating, increasingly mandating payment parity, payment mandates that they have to pay, and payment parity that they have to pay the same as an office visit. Joel, you and I are both from Illinois, from Chicago originally, and just last week, Governor Pritzker signed a very strong telehealth bill law that they have to pay, and they have to pay at the same rate. So the politics is changing. With Medicare, Medicare can only change benefits on a permanent basis through an act of Congress. So, good luck on that most of the time. But now there really is, one of the few things that there really is bipartisan support for is changing those laws and keeping those changes permanent. And there's both bipartisan bills that have been introduced in both the Senate and the House. And I can't imagine they're taking Medicare benefits away from people. It just would be politically unpalatable. So I'm quite sanguine about that.
Cool. Steve, with your experience in the MSO world and with the independent physicians, all these changes just cause a lot of havoc for them. Do you want to talk about that and how they're addressing it?
Yeah, I think it's an interesting comment about the business that I mentioned that we are rolling out. The change that we're seeing from them is an attitude. And so when you talk about what happened with COVID, I think to some of Joel's comments, the pressure it put people under, it didn't even just put them under pressure, it just punched them in the face with reality. Physician-owned hospitals, the 10, 20, 50 doctor clinics, the surgery centers owned by doctors, again, not your 200 owned by tenant, but your 20 owned by 50 or 60 doctors. These guys all were shut down and they lost 2, 3, 4 months of revenue. One CFO I talked to just this week said, it's probably going to be a 3-year process to try to recapture that revenue. And it's not even about the revenue capture as much as it is, there are patients, as Joel mentioned, that put off knee surgeries, hip surgeries. Now they're even worse off. They're 6 months or a year behind the surgery, and then that means behind the physical therapy. And so there's a lot of downstream, issues that was created. And we all think it was just because they were closed, that, COVID closed the location. That's not exactly what happened. Being punched in the face from a independent provider sense is being told by your supply chain partner, Cardinal, Medline, whoever, you just don't matter. We're going to take all the product that we have, millions of boxes of stuff, and we're going to give it to the big boys. We're going to give it to HCA. We're going to give it to Ascension. These hospitals and these doctors were basically told, we don't care about your revenue. We don't care about you staying in business. We're not going to give you the product that you're allocated for, right? You're part of Cardinal, you're part of Owens and Minor. You're allocated 10,000 units of something every month. Well, those guys were told, and by the way, this is still happening. I have 3 hospitals I spoke with this past week that are all still being restricted. So their 10,000 allocated has not been reallocated to them since last March. They are only at 70, 75, 80%. So if you're buying 10,000 gowns a month and now you're only buying 7,000, you literally don't have enough gowns to see patients, and they have to choose how to keep open or which, ORs or which clinics to close. So I think what you're going to see here, and this is kind of what Karma's pushing, obviously, we're an independent-minded group. You're going to see these doctors coming out of this malaise of it's all going to be better. We're going to be told someday it's over. And over the last couple of months, it's been, this is never going to end. We finally realized that they could continue this process for the next 3 years. So the business that we are pulling together, as I mentioned, kind of an Amazon-esque healthcare marketplace, is because of this need. We are trying to help the smaller organizations that felt this pain and that are still being told that they do not matter as much as the big boys, that they now have to start becoming more proactive in managing their business. We're helping them understand how to set up procurement supply chain in a way that's more, not only owned and maybe even vertically integrated by them, but if anything, if they don't want to have total ownership of it, that they have some controls, that they have some, leadership in that process. So that's one of the big things I think we're going to see coming out of this. The other reason why we think that, and again, the comment being that the doctors are going to be more inclined to be independent and to think about these things, is that these doctors, the 2 MSOs that we helped set up this past year, were doctors being told, get out. It wasn't doctors who were strong-minded guys who were like, oh, we're going back out of the health system and we're going to take over the city of Wisconsin again. No, these were 10 doctors being told by a health system, we don't want you anymore. The math doesn't make sense. After we consolidated, we realized the money doesn't make sense for us. You're going to start seeing this more and more across the country. There's going to be a wave of physicians coming out of these consolidated, discussions. They're not going to be employed anymore. We are hoping to give them a landing spot, somewhere that they can come in and just plug and play, hence the ecosystem that we built. We want doctors to feel like, the pressure is not on them to figure all this out tomorrow. But again, I think all of us are going to be dealing with this. You're going to see, potentially the health systems having less, I wouldn't say buying power. They're still going to have buying power. They're just going to go from buying 50 million things a quarter down to 35 million or 45 million. They're still going to be massive, but you're going to see, maybe the balance of employed to employed to independent is 60-40, 65-35 right now, and it's the most we've ever had in the country's history of employed physicians, because physicians are the most independent entrepreneurs in the country, typically as a class of business professionals. We think it's going to go more to the 50-50 and start hedging back out to where it used to be 60-40 independent and 40 employed. So that shift is going to take the next 3 to 5 years. And quite honestly, we think it's going to just be an absolute feeding frenzy on all of these opportunities that we're talking about, from that, even the larger side, how the health systems deal with it, how they really start to compete. You're starting to see hospitals, we're working with physician-owned hospitals that are specific to ortho, who are starting to realize they're giving away business, and they're going to start bringing in infusion services that they never had. And they're going to hire family doctors and general practitioners, so they don't have to push patients out of their hospital or out of their community into a health system competitor. So I think that's what you're going to start seeing is the shift over the last probably 3, 4, 5 years that we've talked about, because I've been saying this stuff to doctors for 5, 6, 7 years, that they need to start realizing Walmart is their competitor, not UPMC. They have to be worried about CVS and Optum vertically integrating and now becoming doctors, right? Optum is now becoming a competitor as a provider of care. So COVID smacked them in the face, and they're now saying, oh God, we have to do everything we talked about for 5 years in the next year. So I think that's what we're going to see is a really big shift, and it's going to affect every part of the business that all of us are in.
Yeah, Steve, I think we play in some of the same circles because we are seeing that vertical integration definitely across a lot of the clients that we work with. You have the hospital, the payer, and the providers, and we work with all three, but they're all trying to lead the vertical integration. So the insurance companies are, building mini clinics and buying physicians. The hospitals are buying physician groups, and obviously they already have the clinics, but they're creating their own insurance products.
Yep.
The providers are doing everything they can to band together because, as you said, being a lone provider, you don't have much leverage. You can't negotiate your fees with the insurance companies. You can't increase your percent of Medicare. You don't matter as much as a large group or a hospital. So.
And I think the big thing on all of this as well is the AMA and the AHA and these associations have failed, and I think the doctors feel that way. They're not being represented. There's nobody looking out for them. All of these associations have become businesses, have become, thought leaders in the world of being politicalized and everything. They're not there defending the doctor anymore. So to your point, Optum, hey, we're never going to compete with you. You're one of our members. You're our partner. Well, that went out the window real fast. And now, like you said, they're moving into a world where the doctors can't ignore it finally. So I thank COVID in the sense that, I'm a very big believer that we need to have this independence with physicians. We don't need decisions being made for our bodies, for our parents, where you're not being given a test because insurance says no, it's too costly. Meanwhile, the doctor's sitting there telling you the only thing you need is this test, but you can't get it authorized. There's too much of that. Obviously, there's that happening for the last 5-10 years. And the doctors, I think, even on that level, are starting to say, I need to control my practice again. I need to start coming back. And I think we're going to see the formation of new associations, organizations. I can tell you right now with the business that we're working on, I was the exact opposite of you, Merritt. I learned your lesson because I saw it with healthcare, with telehealth. We are not the field of dreams. We will not build it and you will come. You will come, you will commit, you will put your money in, and then we will build is how we're moving forward. So we have, upwards of over 100 physician-owned hospitals that we're in contact with that are all coming to the table right now. We're looking to pull their, $1 billion, $1.5 billion worth of volume to give them the power that you're talking about, to give them that strength of voice. So it's an interesting time because this type of conversation would never have happened 3, 4, 5 years ago.
Hey guys, can I jump in here just for 1 second? It's Marty again. So just real quick, you're talking about how, physicians are going to disperse, but one of the reasons why all the physicians sold their practices to hospitals because it was so expensive and the regulatory environment was very negative. So can you discuss, how that's changed? Or, I know you've discussed a little bit, but how is cost going to go down for these physicians breaking out?
one comment just for me, and then Doug, feel free to dive as deep as you want. I just don't know if that's exactly true, Marty. What we saw and what we've heard a lot of is that the numbers being offered were stupid, and the math doesn't make sense post-buy. These doctors were offered, a premium on their business where it made sense to give up their business for that cash. And then what's happening is the hospitals, now that they've owned that physician for 3 to 4 years, you're taking a guy who was working 60, 70 hours a week, who's now only working 40. And you're taking a guy who saw 30 patients a day, is only seeing 18 to 20. So when you're an employee, you're just not going to have that output. And that's what a lot of these guys are seeing as far as the health systems. That's why the practices that we've talked with, or that I've mentioned, have been quote unquote removed from the health system. They've been pushed out, and the math didn't work. So the consolidation was an overspend. The doctors took advantage of it, and now they're coming back out. And one last comment, this is exactly what we saw, again, whenever I was young in my early part of my career, the EDI situation back in the late 80s, early 90s, the doctors had no idea how to take technology and manage their practice, right? So they went into the hospitals, they got taught, they got their staff taught, and then they left after their 5-year, 7-year contract, and then took their trained staff back out and ran their own practice again. So this out has happened, every 7 to 10 years, and we just think this is the next cycle of it.
Yeah,
I just want one more question also, if you guys can answer, because I have an interest in a concierge practice, of how all this is impacting concierge. That'd be great, because back in the old days, somebody would interview a concierge doctor. Now they just sign up right away because nobody wants to be left without healthcare.
Yeah, I'll say a couple of words, and then I know Joel's got some opinions on this as well. But the challenge from the physician's point of view is healthcare is the only place where you can't really name your own price, right? Everything's parred off of Medicare in one way or another. The private insurance companies, they give you a percent of Medicare. In some cases, you get 75%. In some cases, you can negotiate up to 120%, depending on the size of your group. Now, the challenge is if you're a single independent physician, large healthcare companies that own most of the market, they go to you and they say, we're going to pay you 75% of healthcare. You say, I'm not going to take it. And then they say, fine, don't take our insurance. But what are you going to do when you're an entrepreneur and one of the largest insurance companies says, you can take it or leave it. You can make 75% of Medicare. And are you just not going to take those patients? Are you going to find a different way? That's the end of the challenge. And then as Steve was alluding, if those doctors come together, they can start to put pressure because, if you're a large group, you can go back and go, man, we can go out to the public, we can go out to the employers and put pressure back on that payer. The other side of that is the hospitals. There's an age-old game in healthcare. It's what do the doctors make, and then what do the hospitals make? The hospitals make on a reimbursement a whole nother level than the independent physician. Now, that's the game. The hospitals control a market. It is just what it is. But it's not that expenses are becoming more. Guys, there's a downward pressure on Medicare reimbursements. And then the insurance companies are putting a downward pressure on that. That's why we play in the value-based healthcare. What we do is we go to the blue in the market and we say, hey, listen, with our collection of physicians, you spent $10 million on care for all their members. If we could all work together, put some home care in place like Anthony's talking about, put some mental care in place like Merritt's talking about, and lower the total cost of care, can we split that savings? And we end up, the few ACOs that I manage end up making a significant amount. Now, that being said, all of our contracts have downward pressure again, because it's a race to the bottom. It's, if you can do that, you can do better. Joel, why don't you take it from here? Because I know you also have some opinions on this.
So it's not directly on point, but let me make 3 preface comments. I mean, first of all, I think concierge is a completely sort of separate category from a lot of what we're talking about, because obviously it's not cost constrained. People have decided to pay out of their own pocket to be able to have access or speed or whatever it is that you're going to get with the concierge practice. The second comment is mostly that I think the consolidations that have occurred so far have tended to be focused on owning a large number of those kinds of doctors. It hasn't necessarily been the hospital that's trying to do that. It can be a completely independent company that just wants to be a dominant force in the dental space in some geography, or just in the space generally, or any other practice. The thing that I think is beginning to happen in parts of the country, and our Pittsburgh constituency can maybe comment on this with respect to UPMC, is that there are hospital systems out there that have pretty clearly, based on what they're buying up, decided both that they really want to own almost everything in the vertical. It's not just having hospitals, it's having the ambulatory surgery centers and the rehab clinics and the pharmacy operations. And I mean, they really want to have it all. And at least in UPMC's case, they went out and bought up all the cardiologists and all the oncologists and all the endocrinologists. And now you've got 70% of healthcare spending that you really own. And the rationale for that, which I've heard a couple of talks on, essentially was that UPMC, which, you know, is kind of up there with Mayo and the Cleveland Clinic and I mean, the best hospitals in the country, more or less reached a decision that they don't need CMS or any of the insurance companies telling them what best practices are. They know what best practices are, or they think they know what best practices are. And sometimes best practices are different than what we're actually going to get paid for. But if they're the payer and they're telling me that, then I've got to respond to it. And so what's the solution to that problem? Well, I have a son who went to Carnegie Mellon back in the early 2000s. He's been in Pittsburgh ever since. He's had 3 different employers there. His insurance company in all 3 jobs has been the University of Pittsburgh Medical Center. And so by becoming the insurer and the provider, you know, they're in this position where they're basically saying, we take in the revenue at the top, whatever we spend, whatever's left is basically profit, plus we're a nonprofit, so we more or less get to not pay very much taxes on it. And if we can take better care of you as well, maybe those savings we expect to occur won't happen this year. But if you were going to have a heart attack at 45 and now you're going to have it at 65, then we've done a hell of a job, and you know, we'll get a lot more in premium. I think you're seeing the same thing in Mayo's march across the Midwest. I mean, I was stunned the last time I was in Chicago to realize that they now own every one of the best suburban hospitals in the Chicago area. I understand Northwestern and the University of Chicago aren't going away, but you know, clearly Mayo is marching towards them. The Cleveland Clinic owns Jacksonville and Cleveland. I don't know where else they're going to march, but you know, they own a couple of decent sized cities. This doesn't work as well in a place like where Anthony and I live, in the sense that, you know, we're still in this place where, or any really big city. I mean, it doesn't really work in Manhattan either, but on the other hand, Northwell's doing it out on Long Island. Here, you unfortunately are still in a place where we're a big enough city that Georgetown is fighting with GW and both of them are fighting with Inova. And then biggest hospital in town is Sidley, and that's owned by Johns Hopkins, which is all at 27 miles up the road. So, you know, until either Hopkins ends up taking over everything or somehow this sorts itself out, we won't get to quite that stage. But there are a lot of jurisdictions where the hospital system has, I mean, you just saw Aetna merge with CVS. I mean, everybody is beginning to find a mix there.
You got it. We only have about 5 minutes left, so I want to give each one of you all about a minute to kind of just summarize and say where you think the future of healthcare and the future investments are. Anthony, I know that you asked to lead this, so if you could start, and then we'll kind of roll through, and then we'll summarize up.
Yeah, thanks, Doug. Again, great panel. I really appreciate everyone's view and expertise. I think we have a really great and diverse view here. My view is the market is going to continue to shift to care at home, and I think others may agree in different respects. I think we're going to see, for particularly the 65 and over, a lot more focus on care to really be proactive, and that's somewhere where INF Care has really mastered and focused our efforts. And so we're going to continue to see the market evolve and really kind of build out the care continuum, put more emphasis on home care agencies, and really kind of fix the model for them, because right now the model, when it comes to the finance side for home care agencies, it's just broken. The costs are too high, their margins are too low. You know, they're dealing with a lot of workforce challenges, and you know, costs on their operational sides are just going up. So, you know, we see it as more focusing at home. And again, thank you, everyone.
Cool. Merritt, you want to go next? Did we lose Merritt?
So telehealth is here to stay, is going to continue to grow. Behavioral health, mental health is here to stay. Over the last 10 years, the demand for mental health care has continued to march forward. Before COVID, in the 5 years before COVID, the diagnoses nationally for clinical depression, major depression, went up by a third, which is amazing. That's like a third more heart attacks in 5 years. And of course, COVID simply supercharged that demand. Meanwhile, the behavioral health resources are static at best. So telehealth and mental health are inextricably combined, because what telehealth is basically is a more efficient way to deliver those services which are in scarcity and are going to be in scarcity for as long as you can see. Mental health is the killer app for telehealth. And just going to a point that Al made earlier, or Joel, excuse me. We have We have partnerships with 3 departments at UCSF, which is really the leader here in the San Francisco area. It's not because they don't have behavioral health. They just don't have behavioral health that they can get any service from, because they're overloaded. So there's just continue to be huge opportunities for people that know how to do mental health and telehealth right, and see how they combine together. Thank you.
Perfect. Paul, how about you? Summarize us up and what are the opportunities?
Absolutely. Yep. Thank you, Doug. Appreciate it. And yeah, we think there's a ton of opportunity in healthcare services broadly. Our entire model is to, go to the most attractive high growth areas of healthcare services, which in our opinion include pharma services, life sciences tools, revenue cycle management, temporary healthcare staffing, home health, other services related end markets, and back founders that in fragmented markets that want to execute a buy and build strategy. So we think there's a ton of opportunity across the country and in a variety of healthcare services end markets, including the handful that just mentioned at the outset there.
Perfect. Steve, Joel, do you have any final words for us? Steve, I'll let you go first.
I would just say, thank you very much for the time today. I don't think I can add to the where to invest comment. You guys covered it pretty well, and I agree with everything said. I would just say, as a consulting firm, we have talked with over 150 companies just in the last 12 months. We do have a pretty good cycle of interaction with vendors and service firms, IT companies. So we are always seeing companies looking for funding. If anybody would have any questions about specific targets, be more than happy to help and happy to talk to you offline. But thanks again for your time today and for having me.
And Joel?
So I would only add to what I said before, that if you sort of take that to its logical next step, places like what I described are going to be increasingly interested in both devices that are able to target smaller and more individualized parts of your body, drugs that are able to do the same. So I do think there continues to be a very robust opportunity in the device and life sciences spaces. And I'll stop there.
Cool. Everyone, thank you for your time today. That was actually a great conversation. I don't think it could have gone any better. And I think we touched almost every aspect of healthcare. So I appreciate it very much.